Good afternoon, and thank you for your patience. My name is Alex Smith, and I'm the Senior Policy Manager for AIDS United. Welcome to a webinar offered by the HIV Healthcare Access Work Group of the Federal AIDS Policy Partnership entitled Proposed Changes to Medicare Part D, Impact on Access to HIV Drugs, and What You Can Do. First, we'll go through some housekeeping and the agenda, and then we'll go through the content of the webinar. As you noticed when you logged in, all participants are in listen-only mode. This is to cut down on any background noise during the webinar. And as you just heard, the webinar is being recorded and will be available after the webinar concludes to share with your networks and to review should you need to do so. Joining us on our webinar today for the agenda is Sable Nelson of NMAC, who will give an overview of Medicare Part D and why it matters for people living with HIV, followed by Amy Killalay of NASDAD, who will talk about the proposed rule and the potential impact for HIV medication access. And then we'll go into advocacy priorities. I will take part in that, and I'll be joined by Ramon Gardenhire of the AIDS Foundation of Chicago, Carl Schmidt of the AIDS Institute, and Phil Waters of the Center for Health Law and Policy Innovation from Harvard Law School. After that, we will have some Q&A. If you notice in the bottom left-hand corner of your screens, there is a Q&A box. If you have questions throughout the presentation, please type them into that box, and we will address them once we get to the Q&A portion. Everyone will remain in mute throughout the entirety of the conference. There we go. Right. And to give an overview of HCOG, it is a working group and a coalition of over 100 national and community-based HIV service organizations representing HIV medical providers, public health professionals, advocates, and people living with HIV who are all committed to ensuring access to critical HIV and hepatitis C related health care and support services. It is a work group of the larger Federal AIDS Policy Partnership, and we are excited to offer this webinar to you today. Our objectives for today are to educate the HIV community regarding Medicare Part D and its importance for HIV access, raise awareness regarding the proposed rule from the Trump administration to change the Medicare Part D protections and how it could impact HIV access to medications, and to mobilize the community to get involved in advocacy to protect Medicare. First, for an overview of Medicare Part D and why it matters for people living with HIV, I'll turn it over to Sable Nelson of NMAC.
Thanks, Alex. Good afternoon, everyone. As Alex mentioned, my name is Sable Nelson. I'm a policy analyst at NMAC. And to begin, we're going to briefly explain a little bit about the Medicare program. So what is Medicare? Medicare is a national United States insurance program for people 65 and older. It's also for people with certain disabilities and end-stage kidney failure. There are different parts of the Medicare program that cover specific services. Medicare Part A covers inpatient hospital stays, care in skilled nursing facilities, hospice care, and some home health care. And Medicare Part B covers medical insurance, certain doctor services, outpatient care, medical supplies, and preventative services. Next slide, please. The Part D benefit, the Part D component of the Medicare program is what's going to be impacted by the proposed changes that we're going to be talking about in this webinar. And Medicare Part D is the prescription drug benefit. It covers, it adds prescription drug coverage to original Medicare, some Medicare cost plans, some of the private fee-for-service plans, as well as the medical savings account plans. These plans are offered by different insurance companies and other private companies approved by Medicare. Next slide. Now, the purpose of this slide, and as you can see on this pie chart, it shows that Medicare has made up nearly half of the federal funding for HIV/AIDS care in fiscal year 2016. Medicare enrollees people who are living with HIV are increasing in number but in terms of the overall Medicare population, they make up about 1% of the overall Medicare population. It is estimated there are about 120,000 traditional Medicare fee-for-service beneficiaries who are people living with HIV. And currently, as things stand right now, Medicare drug plans cover all antiretroviral medications. And now I'm going to turn things over to Amy, who's going to talk to you about what some of these proposed changes are. And a little bit about the current state.
Terrific. Thank you, Sable. Hi, everyone, and thanks to AIDS United for hosting. Yes, as Sable pointed out, we're going to be talking about some of the changes to the protections that have existed in the Medicare Part D program. And to start out, let's sort of start with the protections that as they stand right now. And so as of right now, the antiretroviral class is one of 6 protected classes in the Part D program, and this has required that Part D plans cover all or substantially all drugs in one of these protected classes, and limiting the utilization management plans can apply to drugs in these classes. So that's kind of our current state of affairs, that antiretrovirals have been protected since the inception of the Medicare Part D program. So next slide. And the proposed rule out right now changes the 6 protected class protections in 3 major ways, sort of outlined in the slide in front of you. The first is that the rule would allow increased use of prior authorization and step therapy, and we'll talk a little bit more about the specifics of that part of the proposal. The second prong proposed change to the 6 protected classes is that plans would be allowed to exclude a drug from a formulary if the drug represents only a new formulation of an existing single-source drug, regardless of whether the older formulation remains on the market. We'll talk a little bit about sort of implications for HIV there and what that means. And then the third part, and sort of arguably the most controversial part, the rule would allow plans to a protected class drug from the formulary if the price of the drug increased beyond a certain threshold over a specified time period. So I'm going to walk through each of these 3 prongs kind of one by one and talk both about what the rule says and then potential implications for HIV medication access. So next slide. So to start with the utilization management provision, and this is sort of the most significant, I would say, change in terms of impact on access to medications among the 6 protected class groups. And the provision of the rule really does weaken the protections that have discouraged utilization management from being applied to the 6 protected classes. So we're going to be talking about 2 forms of utilization management in particular that are at issue in the rule. The first is prior authorization, and the second is step therapy. So just a very quick review about what those things are. Prior authorization, when your doctor has to get approval from the plan before the plan agrees to pay for the drug. So often, justifying why the drug is medically necessary or that it's being prescribed in accordance with its indication. And then the second one, step therapy, also known as fail first. So the requirement that an individual try a less expensive drug first before being allowed to access to a more expensive, often brand name medication. And these things are essentially cost-saving measures for plans. That is sort of the purpose behind them. They are designed to limit access to higher cost drugs if there are other alternatives. So next slide. So as I said, Medicare regulations have historically limited the use of these 2 utilization management techniques for the 6 protected classes. It's sort of one of the core things that makes the classes actually protected. And for HIV drugs have historically been even more protected than the other 5 classes. There are some unique features of the HIV class that have sort of warranted additional protections. For the other 5 classes, prior authorization and step therapy have been a little bit more common. They've been allowed. They have been sort of allowed on a very limited scale. But the prior authorization and step therapy have essentially been off limits for HIV. And I'll just note, without getting too far into the weeds here, there's not a specific provision in the regulation that has sort of outright forbidden use of step therapy and prior authorization for the HIV class. We've got explicit reference to the HIV treatment guidelines, which is in existing regulation. The reference to the treatment guidelines is in the proposed Rule 2, which is a good thing. And then we've got sub-regulatory guidance sort of interpreting the regulation in the form of the Medicare Part D manual that has strongly discouraged use of prior authorization and step therapy for HIV. So our current state of affairs has really been that those two things are not at play for the antiretroviral class. And so what the rule does is sort of expand the use of prior authorization and step therapy across the 6 protected classes. And by the rule's sort of own admission in the preamble, this is explicitly to bring the 6 protected classes and sort of the utilization management techniques allowed in them more in line with commercial practice. So the two sort of major things to think about here in terms of how prior auth and step therapy are being expanded is that it would be allowed across the 6 protected classes at both initiation, so someone sort of new to the specific treatment, as well as for folks on an established regimen. And so that's part of the expansion piece for the other 5 classes as well. And then the second piece is that prior authorization would be allowed to be used to determine if the drug is being prescribed for an indication that is actually attached to the protected class. And just to give you like some example of what exactly that means, the rule preamble gives the example of the immunosuppressant class and immunosuppressants being used to treat a range of other conditions not associated with the protected class indication of a transplant rejection. So that is the example the rule gives of why they're sort of adding this other layer to prior authorizations. You're not only using it to sort of ensure that the drug is medically necessary, you're also using it to ensure that it's being prescribed for an indication that is explicitly attached to the protected class. So next slide. So loosening the protections around use of prior authorization and step therapy could have a significant impact on access to HIV medications. And this is true for a couple of reasons. There is a reason why HIV is a protected class, and that reason has not changed, in the years since the protected classes were specified. The treatment regimens are complex, and treatment decisions are highly individualized. One-size-fits-all model simply does not work for HIV, and I think, we think about who is on the Medicare program as Sable sort of specified for us. This is a population made up of folks who are older and who have been living with HIV for a long time, or folks who qualify for the program because of are disabled. For the Medicare population, you're likely to be living with another comorbid condition. So this is a population for whom it is particularly true that individualized treatment decisions are really, really necessary. The other piece here, I think as I alluded to at the outset, a lot of the provisions that we're talking about are aimed at cost savings. They're aimed at either getting at, sort of overall drug pricing or, keeping down the cost of the Medicare Part D program. And, I think it's important to note that as a cost-saving measure, not, sort of putting aside the individual and public health implications, as a cost-saving measure, increasing utilization management in this way simply does not work for HIV as the current treatment landscape stands. Well, things may change on this front, and I think there's reason to believe the HIV treatment front is changing and will change. Right now, there are very few generics available for HIV, and certainly no standalone generic treatment regimen. So that means that essentially every person living with HIV is dependent on at least one brand name medication, and this puts HIV in a very different position than some of the other protected classes where generics are far more common. And so I just want to point out, CMS itself acknowledges in the preamble of the rule that the treatment landscape for HIV makes utilization management not a super effective way to get at cost savings. So, chipping away at the codified protections is not going to get at the chief aim that CMS sort of puts out for this rule and could cause both consumer and provider confusion and potentially discriminatory plan practices. And then finally, a quick point on this, because I mentioned the expansion of how plans can use prior authorization. So they can now use it not only to verify that the drug is being prescribed correctly, but they can use it to determine if the drug is being prescribed for a protected class indication and exclude coverage if they find that it is not being prescribed for a protected class indication. This should be limited to the sort of cut and dry immunosuppressant example that I gave earlier, but I do think it's worth mentioning that PrEP right now is an ARV medication, a once daily pill that falls within the protected class, and that CMS really needs to be aware and to regulate plan activity when it comes to PrEP to make sure it doesn't inadvertently get caught up in this new prior authorization flexibility. The last thing that I will say on this is that I think it is important to kind of look at the policy goals that are sort of outlined and behind the rule. And I think, it is an important policy goal to identify plan designs that can incentivize cost-effective use of care and cost-effective medications. And I think, that's sort of probably a laudable goal across many HIV entities and coalitions. But I think the problem with some of the proposals and some of the weakening of the utilization management techniques that we just talked about is that they end up being punitive to the consumer rather than actually promoting cost-effective care. So proposals that could incentivize value-based plan design, for instance, that are in keeping with HIV treatment guidelines, may be a better way to get at the ultimate goal here. So next slide. So I'm going to walk through the second and third prongs now, and I'll just note that these are provisions that different groups may come out differently here. So I'm just going to go through some of the top line components here. So I'm going to start with prong 2. Under current rules, so as it stands now, Part D plans are allowed to exclude newer, higher cost versions of existing drugs with the same active ingredient or extended release products when the immediate release product is included. And so this makes sense. The Part D program wants to incentivize generics and cheaper alternatives as drugs come off patent. However, there's sort of a bit of a loophole as how that kind of bumps up against the 6 protected class protections in that manufacturers can pull the older product from market, forcing plans to cover the newer product as the only one available. And so this is a fairly sort of well-known patent extending practice called evergreening. And what the rule does to kind of address that is to allow Part D plans to exclude the newer, more expensive product, even if the manufacturer withdrew the newer product from market. So this is just a way to sort of disincentivize manufacturers from pulling the older product from the market and sort of getting at access to generics, access to lower cost equivalent medications as they become available. So next slide. So, why does this matter for HIV? I think, for many of us, sort of incentivizing generics and lower cost medications is a priority in terms of increasing overall access to treatment. So that certainly the provision is really aimed squarely at that goal. I think some considerations as you're looking at this particular provision and sort of deciding whether and how to weigh in on it is that one sort of caveat in the proposed rule right now is that the provision wouldn't apply to products that offer a unique route of administration. So that it really has to be like you've got a very similar product that is new, that is similar to the sort of older, cheaper product. If you've got a unique route of administration, that does not come under this provision. And so it's important to ensure, one thing that's a little bit murky in the current rule is that the definition of what it means to be a new formulation is not well defined. And so, I think it would be important to consider, ensure that medications with unique adherence or efficacy benefits, such as, for instance, single tablet regimens, are not under that definition. That is just sort of a consideration, for this particular prong. And so next slide. And finally, the last prong of the rule, and as I said at the outset, arguably the most controversial, the rule would allow Part D plans to exclude a drug if the wholesale acquisition cost, or WAC, and this is essentially like the list price of the drug, has increased at a rate greater than the rate of inflation measured by a particular way that you can measure inflation. There are many ways you can measure inflation. What the rule uses is Consumer Price Index for all urban consumers. So the purpose of this provision is fairly clear-cut. It's really aiming to get at rising list prices of drugs. That is sort of the long and short of it. I think the numbers bear that out sort of across many of the protected classes. Certainly for HIV, drug price increases have outpaced the Consumer Price Index. So that's kind of the bend behind it. And I think what I would say here too is that I think the concerning part about this piece, and I would say sort of consideration here, is that while I think that many of us do support drug pricing provisions, it is concerning that part of this proposal is the potential to exclude new drugs from the formulary, and that could put consumers in the middle of sort of this showdown between plans and manufacturers. So that is a concerning sort of component about this particular and again, like very much sort of out there controversial drug pricing provision. So with that, those are the three prongs, and I'm going to turn it over to the next session to sort of talk about what do we as a community do now.
Thank you, Amy and Sable. That was absolutely tremendous in helping to kind of lay the foundation for why this is so important and why the community needs to engage and activate around this. Again, I'm Ramon Gardhart with the AIDS Foundation of Chicago, and we're going to hear from some really dynamic and learned speakers, particularly about what has already happened in the realm of advocacy around this issue and what can continue to happen moving forward, particularly as you as individuals and as organizations who are involved in this work. So I'm going to be joined by Carl Schmidt from the AIDS Institute, Phil Waters from CHOPE, and Alex Smith from AIDS United. First up, we have Carl.
Great. Thanks, Ramon and Alex, for organizing today's webinar. So two places that we really need to focus on, as Amy outlined, there's really bad elements that really hurt patients. And it's really important that we fight this through our work with the administration, and also the Congress could be helpful as well, since they have they speak up and they could influence what the Department of Health and Human Resources Services concludes. But first, with the administration, it is really important that all of us provide comments by the deadline, and I assume other speakers will be talking about this, and that the sample comments that we will be preparing and sending out. But it's really important that we get as many comments as possible into the administration by the January 25th deadline. It's important for people living with HIV and providers and doctors to do that. But also, we are doing individual and coalition work with the administration as well. It's important, this came from CMS, which runs the Medicare program. But there's other parts of the federal government that have direct, control and involvement with HIV treatment and prevention, and that's HRSA and CDC. So it's important to talk to them. I know I have and other groups as well, but it's really important that they weigh in as well. Also, we're working on getting a meeting together with the head of Medicare for some HIV doctors and members of the Healthcare Access Working Group. We're also, I had a meeting with the secretary recently, brought up this issue, and as I don't know if people heard or read his comments before the Ryan White conference in December. He brought up this issue. He said that he understands that the community has concerns about this proposal. He said that we don't want to do anything to hurt people with HIV/AIDS. Well, if he says that, then why did he propose this? But he did say that, this is just a proposal, and we do want to hear from you. So I think we really need to take him up on his comments, and we really need to make sure that they hear from us loudly. And we just have a couple weeks to do it. Also, Congress has a role as well. We're doing a number of visits, both the HIV community and working with the other classes that are affected by this, like mental health and cancer, the transplant community, epilepsy community. But they also really need to hear from the grassroots. And so I would encourage people to raise this very important issue to your members of Congress. I know a lot of members of Congress are focused on drug pricing these days, but, so they may say, oh, this is an effort to lower drug prices. No, it's really an effort to hurt patients with HIV gaining access to their medications, and we have to let our elected officials know about that. Thank you very much.
Thank you so much, Carl, and thank you for all the amazing work that you have been doing on this really important issue. And next up, we have Phil Waters from CHOPE.
Thanks, Ramon. So I think Alex is going to go through this a little bit more, but we mentioned and Carl mentioned the need to submit comments, and I just wanted to sort of take a minute and expand on that a little bit and talk about why you as both an individual and an organization should consider doing this. So anytime a federal agency wants to change their regulations or issue new regulations, they are required to put out a draft and must accept public comments on that proposal, which gives you a very, very important opportunity to formally make your voice heard. And while it might feel like the other side's not listening, documenting your concerns in written comments is important for a couple of reasons, at least as I see it. First, we wouldn't want the administration to sort of hear nothing from our community, proceed with the proposals as they're written, and then say they never heard anything from the HIV community, and so they thought it was all fine and dandy. The second reason I see is that having those written comments submitted means that they enter what we call the administrative record. And having a strong administrative record is important if, for, say, example, the regulation is passed as proposed and then a later administration comes in and wants to come back and revisit it. Having a strong administrative record with commenters expressing their concerns gives them more justification to change course later on. So if you're concerned about what to say in these comments, we've given some great information about, some considerations for people living with and at risk for HIV. But we're also going to be releasing our HCOG Coalition comments sometime by next week that you can use as, sort of draft template comments there. Also, the HIV Medicine Association and the American Academy of HIV Medicine have released a sort of alert and template comments you can find here at this link that we provided here for you. But in any case, if you're using template comments, please try and customize whatever you're going to say. While quantity of comments is very, very important, and we do stress that quantity is important, quality is important as well. Comments that are sort of too similar to one another sometimes end up getting lumped in together and counted together, and those counts can be somewhat important later on the line. Templates and other comments are a great starting point, but at a minimum, make it personal. Include information about yourself, your organization, any personal stories you have with access in Medicare, and how this would impact either you or the clients that you serve. So next slide. So how to submit these comments, I think Alex is going to talk a little bit about a custom landing page that you can use. But you can also comment directly through regulations.gov, and so we've given you the links here directly. We'll sort of send around the slide deck so that it's easy to find. And we've linked you here directly to the proposed regulation because otherwise there's a bit of hunting involved. And importantly, Carl mentioned comments are due January 25th by 5 p.m. Eastern. We've made this pretty easy for you, so please consider submitting a comment. And with that, I'll turn it over back to Alex.
Thank you so much, Phil and Carl. So as Phil said, AIDS United has launched or is building a national effort to fight the administration's rule on the changes to the protected classes in Medicare Part D. And while the fight will continue after the comment period closes, our most urgent effort is collecting and submitting as many public comments as possible, opposing the rule before the deadline at 5 p.m. Eastern on January 25th. And of course, we cannot do this without you, and I'm going to talk about 3 ways that you can help. The first is to tell the administration why you oppose this rule and to submit a unique comment. And what I mean, and Phil touched on this, but if your comment is exactly the same, like through a form letter that you often see on action alerts to members of Congress, that will be lumped into other comments that are considered to be the same, whether they are identical or less than 30% unique. So AIDS United has put together a custom landing page that will launch this Friday at noon. So noon Eastern, the website mystatusmymedicare.org will launch, and it will have 3 different types of comments. One for people living with HIV, one for HIV medical providers, and one for advocates of people living with HIV. So you would just click on whichever category applies to you, and you'll be taken to a system that will be preloaded with a comment to the administration that has a section in which you should type in some customization about why this rule is important to you and why you think that the administration should rethink this portion or all of the rule concerning the protected classes, specifically antiretrovirals. We know CMS pays attention to these comments, and they're our best hope of blocking this dangerous rule. So when that launches on Friday, I hope you share that URL with your networks. And that's the second plank of this, is to ask others to voice their opposition. We'll have sample social copy and graphics, as well as a template email that you can send to your organization or your networks asking them to submit a comment. I will share that toolkit with everyone who attended this webinar, as well as the broader HCOG and FAP distribution lists ahead of the launch on Friday, so you're ready to go when we launch the campaign. And the last thing you can do is share your story. We're looking to highlight the potential real impacts this rule could have, and are looking for people living with HIV, healthcare providers, and other advocates to participate in testimonial videos, op-eds and editorials, and earned media opportunities. If you are interested in that, in being in a video as part of this campaign, or to write an op-ed to your local or regional media source, please email Kyle Murphy, the Director of Communications for AIDS United, at kmurphy@aidsunited.org, and we will be providing compensation for this, a $50 gift card for every hour of your time. So if you are interested in that, please contact us as soon as possible so we can get you looped into this campaign, and so it can have as much impact as possible. Again, that mystatusmymedicare.org will be the landing page for ease of submitting comments, and that campaign will launch this Friday, January 11th at noon Eastern. This wraps up the content of our webinar, so we would welcome any questions that you may have. We do have a couple questions that we'll get to in just a moment, but as a reminder, if you have a question, please type it into the Q&A box in the participant feedback portion of your webinar screen. And the first question we have is, how would this affect persons living with HIV who are receiving Medicaid and Medicare?
I can start there, Alex. So when
Sure.
compared to the overall Medicare population, beneficiaries who are living with HIV are generally dually eligible. About 69% of the individuals who are people living with HIV are dually eligible for both Medicaid and Medicare. So it would certainly have an impact there. And in terms of how would it impact their prescription drug plans, Currently, all states offer outpatient prescription drug coverage, but each state can choose which medications they are willing to cover and which prescriptions they will not cover. So because if somebody is dually eligible, it would be, and their prescriptions are covered through Medicare, they would definitely have their prescriptions, they would be able to obtain those prescriptions that way. But if these proposed changes go through as suggested, they would possibly lose eligibility and access to those medications. Does anybody else want to clarify or add?
This is Amy. I think that I would just say, I think in terms of thinking about impact on the dually eligible population, that is probably a really good sort of point to sort of underscoring comments in terms of the folks that we're concerned about, and that we really need to ensure access to the appropriate treatment regimen. The dual eligibles were one of the groups sort of explicitly called out when the 6 protected classes were originally sort of envisioned and implemented. So I think that would be a really important sort of piece to really underscore in comments.
Thank you both for answering that question. The next question is our meeting schedule that we can join in, specifically Hill meetings. I know that there is a strategy call that's going to happen among the HCOG, and in which we'll talk about administrative and Hill meetings. So look out for those opportunities through the HCOG distribution list. If you have specific ideas about people to reach out to, please email policy@aidesunited.org, and we can work that into the HCOG conversations when it comes to strategy. The next question we have is, can you speak to what people who are not Part D participants can or should do? Phil, can you start us off on this one?
Sure. I think that at the very least, you can still consider submitting a comment. I think as I mentioned, the comments definitely sound are more compelling when you have a personal story. But that's not to say that you can't voice concerns on behalf of a community that you're also concerned with. I think that the aging HIV population has been historically underrepresented, and so I definitely urge sort of speaking up for that group as well.
Great. Thank you so much, Phil. The next question is, assuming this coordinated campaign launching Friday will be an action alert style campaign, can we pull language to use with our mobilization networks? And the answer to that is absolutely yes. Everyone who is on this, who registered for this webinar is going to get our social media and action toolkit before we launch on Friday, so you can use all of that copy with your networks. Let's see. And the next is also, will this participation/recording be shared with the participants? Yes, absolutely. Once we get the recording finalized, which takes a couple of hours after the webinar ends, we'll get it sent out. So it'll probably look for midday tomorrow that we'll get all of the recording and supplemental materials out to everyone who has signed up for this webinar, whether or not they attended. The next question is, would comments be more credible if we suggest other ways to address prescription drug costs, and what other ways do you recommend we suggest? Amy, can you take that one to start?
I can, and I think I would start with, we could have a whole separate sort of webinar just on that specific question. So I think it's an important question for sort of us as a community to be grappling with. I think we are just in an era of kind of having to participate meaningfully in the conversation about drug pricing and its impact on access. So, in terms of comments being more credible or not, like I think, I think we have to start out with what is the threat, and really focus our efforts on that in these comments. For me, I always think that it is helpful to say there are other ways to do this. There are ways to do this in a way that is not punitive to the consumer, and here's what they are. It does require then having that sort of, and here's what they are in their back pocket. And I think, individual organizations and us as a community are sort of coming to different, we are slowly but surely coming to sort of consensus around what that could look like. So I think that is probably an area where organizations may differ. I don't think, HCAG has sort of aligned ourselves on here are the ways in which we think prescription drug costs could be addressed in terms of federal action. I know the Fair Pricing Coalition has done a lot of work in thinking on that. Certainly Tim Horn and NAFDAD have done a lot of work in thinking on that. So I think it's a question we as a community have to grapple with, and I think for the purposes of these particular comments, I would say at the forefront has to be sort of immediate and specific harm to our populations, and then to the extent that you're getting into prongs 2 and 3, I do think it makes sense to probably be thinking about what could this look like if done in a responsible way. I think this is an opportunity to underscore our commitment to reasonable and responsible drug pricing. That has to be part of what we care about.
Thanks, Amy. Does anybody else have anything to add to that? All right. So the next question is, we know this measure is touted as a cost-saving measure, but this effort does not appear to yield the cost savings for which the administration is striving. Do we know if CMS has an estimate of how much they expect to save with this effort? Carl or Ramon?
Well, and maybe Amy too. So they did do a cost estimate, and the questioner is correct. For HIV, it doesn't seem to be much of a cost savings at all. It's from some of the other classes. So, why are they proposing this is the question. And so I'll just leave it at there because the questioner was very correct. It's very low.
All right, another question about pricing, which I think may be its own set of webinars by itself, is what is the better solution to fight outrageous price spikes on existing drugs? And this person also said that it in relation to the third prong of the rule that Amy covered earlier.
Yeah, I mean, this is Amy. I do want to say, I'm not speaking for HFAG. I don't think that we've come out as a coalition, sort of on a unified front on that. I think certainly Fair Pricing Coalition and NAFDAD have thought about sort of alternative regulatory approaches. I would urge folks, if you haven't already, to look at the FBC document that was put out a couple of years ago, authored by Tim Horn and Sean Dixon, that spells out different approaches that could get at rising sort of particularly list price increases. And so, I would direct you there to some concrete sort of proposals, and just say that I think this is a community conversation. I think that's where we are, kind of identifying, okay, this is not it, but what could be the solution that does not sort of put consumers in the crosshair between plans, the federal government, and manufacturers.
Thanks, Amy. Yeah, this is definitely a very complex conversation to have as a community, and I think we are doing that in very many ways. Another question says, it sounds like none of these presenters are seniors. How are you interacting with the seniors who will be directly impacted by these changes? So I'm glad that you brought this up. Thank you all. Thank you for telling us we all have youthful voices. But we are definitely reaching out to, I'll speak from AIDS United's point of view as part of our Save Medicare Part D campaign, is that we are reaching out to organizations across the country that serve older people living with HIV, as well as other Medicare recipients who are living with HIV, to directly involve them with the campaign videos and op-eds and other earned media opportunities. We are also in conversations with several organizations, both national and regional scope, who serve older LGBT Americans like Sage USA, and other regional organizations like Desert AIDS Project and Legacy Community Health, who have focuses on populations aging with HIV. And one of one of our other consultants for this project is Ronald Johnson, who is the former VP of Policy and Advocacy for AIDS United, and he's helping us put together a policy paper about HIV and aging, and specifically leaning on parts of Medicare Part D that are important. And he'll be going on a listening tour, specifically engaging with seniors and other older Americans living with HIV as part of this process to gather what the pressing policy issues are on state, regional, and federal levels, so that can be pulled into a policy paper to be released either late Q1, early Q2 of this year, and that will be part of our Hill and administrative advocacy as well once we get that completed. And I hope that answers this question.
And from the NMAC perspective, I just wanted to interject that we do have our HIV 50+ Strong and Healthy program. We have a network of 50+ scholars from across the country and who also have a very active social media presence. So we're going to be engaging them and activating them to engage their peers as well. The Facebook group has nearly about 1,000 people there, and we have 150 scholars who have gone through our program so far, who will be engaged in, who are involved in what our response is going to be and how this is particularly going to impact individuals over 50 living with HIV.
Awesome. Thank you so much, Sable. The last question we have is, are medications affected if under the 340B program? This rule doesn't necessarily touch the 340B program as far as we know. Amy and Carl?
I think that's right. I think the short answer is no. The 340B program, to my understanding, would not be impacted by the rule.
Great. It looks like that has all of our questions answered. And that brings us to the end of our webinar today. Thank you all so much, Amy from NASTAD, Sable from NMAC, Phil from CHILPI, and Carl from the AIDS Institute for joining us today, and Ramon from the AIDS Foundation of Chicago for serving as MC for the advocacy portion. As promised, we will be sharing the recording of this webinar and other related materials around midday tomorrow. Again, thank you all for joining the HIV Healthcare Work Group of the Federal AIDS Policy Partnership for a webinar called Proposed Changes to Medicare Part D, Impact on Access to HIV Drugs and What You Can Do. Have a good afternoon, and thank you.